We are going to talk about very interesting topics as part of the Advanced Pediatric Endocrinology Symposium. This is being organized under the banner of Mediclasses, Growth Society and Regency Hormone with support from Novo Nordisk. So we started off with pediatric endocrine awareness using workshops, and around 2011 we started the practical pediatric endocrine course. Then we conducted workshops across the country. We had a workshop in Patna also, I think 10 years ago. Then we had got PPC across the country. In Jaipur we conducted. Then we realized that just doing workshop, it will require a huge amount of time and other factors. So we started on more of awareness programs on social media and YouTube channels. Then we started our on-site fellowship, that is 2017. And then we started the online program because that will give more access to people across the country. And now we have the mobile application, we have got the online fellowship programs, the other factors which are available in that regards. So over the last 10 years, we actually, when there was no COVID, we used to have every month one program here and there. And we had got huge number of practical courses, workshop across the country. But now, good or bad or whatever, we've got more of online activities which are there. And this time we have a hybrid program. So the first Advanced Pediatric Endocrinology Symposium happened in 2017. I think Dr. Sanjay and Dr. Pradeep were both there in that program. Dr. Amit was also there in that program, and Dr. Hemchand, who is part of this program, also was part of that program at that time. 2 years back, we had another big program with our on-site course, which was in 2019. Again, many of our friends were there, Dr. Pragya and a lot of other friends. Dr. Pratik was also there at that time. Then last year, we did it more in an online mode, and today it's a hybrid mode. So all of you can access our YouTube channel, which now has got a huge number of videos on nearly every topic of pediatric endocrinology. You can access them from there. You can go to our website, which provides a lot of information and courses which are available, including fellowship programs, diploma programs for postgraduates. And we have got 3 specific exclusive grand rounds which happen on a complimentary basis. Every month we have one for advanced in a fellow or a pediatric endocrinology perspective, one for postgraduates. And recently we have started a postgraduate lecture series for postgraduates covering the basic topics in that regards. You can access our publication. So Dr. Saurabh is a very, very dynamic and young pediatric endocrinologist who is based out of Jalandhar. He has done extensive work in pediatric endocrinology, has been trained at Elderly Children's Hospital in Liverpool and under Dr. Shaila at Manipal in Bangalore. And he has got a keen interest in the management of individuals who have got type 1 diabetes, especially with newer advances in technology. So Saurabh, over to you.
Thank you, Dr. Vajpayee. At the outset, I'm thankful to you and the team for giving me an opportunity to share my views on the newer insulins in 2021. So I would like to take you a little back to 1989 when physiological replacement of insulin was the topic of this New England Journal issue. And it was mentioned that although insulin was discovered and the first administered more than 65 years ago, the goal of physiologic replacement remains elusive, despite major advances in our understanding of insulin's physiological effects, chemistry, kinetics, actions, etc. This was 65 years ago. This year, insulin is celebrating its centenary, and the statement has largely remained unchanged. Now, why do we need designer insulins? Because we know there are gaps. Now, looking objectively at the gaps, what do physicians think? Now, we know that more and more doctors feel that they need to manage both safety and efficacy, but it is difficult to optimally manage with both with insulin. There is a big concern about hypoglycemia, and if hypoglycemia was taken care of, they could treat patients more aggressively. And a significant numbers of patients, we all know in our practice, do not have adequate blood glucose levels, even with insulin treatment. So although insulin was discovered about 100 years back, we are constantly tweaking it. We are constantly making it better to suit the needs. And that is where the design of insulin is constantly changing. And an ideal insulin would have no fluctuation in blood concentration. It would have no glycemic variability and no risks of hypoglycemia. And that is what we are constantly striving for, but only if wishes were horses. And the continuous quest for designer insulins started at 100 years back. Then the first, maybe a little bit designer insulin was the NPH, and then came the era of recombinant human insulins. And after that, there has been a constant upgradation into analogs, then biphasic analogs, basal analogs, faster analogs, and the next generation basal insulins, Degludec, Glargine 300. And the current spotlight is on faster insulins and longer basals. So the newer insulins that occupied center stage throughout 2020-2021 were generation 2 basals, Glargine 300 and Degludec 100, and more importantly, how they have been faring against each other, because we understood in the last 3 or 4 years that how the generation 2 basals are better than generation 1 basals, but how do they actually fare head to head? We'll discuss in this further slides. Faster Lispro got FDA approval in this, and maybe there was a relook at Technosphere insulin, that is the inhaled insulin. Now, just to recapitulate, what makes a basal insulin basal? A lack of predominantly immediate action, slower diffusion from source, and a longer half-life, which translates into a longer duration of action. Now, generation 2 basal insulins, Degludec and Glargine 300, just to recapitulate quickly, what is different in them? Now, Degludec binds strongly but reversibly to albumin via its fatty diacid side chain, because that is where the change has been made, and it results in plasma protein binding of more than 90%. What is the translation into clinical effect? The half-life of Degludec changes to 25.1 hours and a duration of action changes to more than 36 hours. On the other hand, generation 2 basal Glargine 300, there's no change in the sequence. It is the same Glargine, but it has been concentrated into a smaller volume of injection. So it is volume has been reduced by 2/3 when compared to Glargine 100. The basic molecule stays the same. Now, what it is hypothesized is that the more compact subcutaneous depot with smaller surface area leads to a more gradual and slower release from the depot surface. Now, what does it translate into? It translates into a more steady state pharmacokinetic and pharmacodynamic profile. So you see the blue bars, the blue line is for Glargine 100 and the green line is for Glargine 300. The half-life of Glargine from 12 hours changes to 18 hours once you make this tweak in the packing of the same molecule within the drug delivery system. And as we know, as the basals have evolved, the peaks have flattened. From the wide peak of NPH, Glargine was a big revelation. And from the slight peak of Glargine, a more flatter Degludec and more flatter Glargine 300 are what we have right now. Now let us see how Degludec fares versus Glargine generation 1 basal, that is insulin Glargine. Now most of the trials have shown it to be non-inferior. And coming to type 1 diabetes, which we are more interested in, one of the trials has even showed in way back in 2018 that it has a better fasting profile. More or less primary endpoint, it is not inferior to a generation 1 basal. But the switch 1 trial really gave us insight as to why it is a little better than Glargine 100 for our patients with type 1 diabetes. It was a 64-week double-blind target to treat crossover trial, and once daily Degludec was compared with once daily Glargine 100, and then the patients were crossed over to the reciprocal arms. And what it showed was that there is a lesser risk of hypoglycemia with Degludec. Whether you see overall symptomatic hypoglycemia, nocturnal symptomatic hypoglycemia, and severe hypoglycemia. It is important to look at all three separately, because that is where, because this distinction between the three hypoglycemia would come in once I discuss the head-to-head comparison between the second generation basals. Also, most of the trials showed that there is a significant glycemic control there's a glycemic control at a significantly lesser dose compared to insulin Glargine. In addition to this, CGM studies showed a better glycemic variability. That means lesser glycemic variability with Degludec versus Glargine 300, and better time within range and lower time below range. And interestingly, changes in glycemic variability were more pronounced in those who needed it more. So here you see very quickly, the wider the bar, the blue bar you see, the shorter, the more difference between the blue and the red bar. So these blue bars show how much is the glucose varying at different times of the day. The blue is the pre-intervention, and once they are on the red bar is showing the post-intervention. So here you see that the difference between the maximum and the minimum glucose at most of the times in the day comes down. More pronounced in the nocturnal time frame where it is really required. And over time, it has been shown in different studies that the lack of the improvement in the hypoglycemia risk increases as the time duration of a person on the second generation basal increases over time. Here you see both the bars, they diverge. And the relationship between HbA1c and hypoglycemia in those treated with degludec and glargine warrants a little more discussion. Just see on the left side, this is how hypoglycemia fares once you try to reduce the HbA1c. Now, we all know that for a long time, we used to think that beyond a limit, especially in smaller children, you are not going to touch HbA1c. You're not going to strive for a lower HbA1c because you are risking more and more hypoglycemia in that. And that led to a belief in a lot of clinicians, which is still there, that bacha hai, we don't have to be very aggressive, because if you want an HbA1c within target, the child will definitely go into hypoglycemia. Now, see on the left side how hypoglycemia fares in type 1 diabetes. The blue line is the degludec and the other color line is glargine U100. So as your HbA1c goes down towards the left, beyond the value of around 7.5, the curve flattens in degludec versus glargine 100. In simple language, what it means is that you are not progressively increasing the hypo risk as your HbA1c is going down on the newer generation insulins. And this finds a reflection in the newer draft of the ISPAD guidelines, which say that with the children who have access to modern insulins and modern insulin analogs and basals, fear of hypoglycemia should not preclude you from achieving a better HbA1c in those children. And this is where the second generation basal is helping us in clinical practice. Now, comparing degludec with determir, which was its own compatriot from the same company, there is no significant difference between HbA1c when it comes to the second generation versus the first generation determir. There is a significant difference between the fasting plasma glucose levels when you shift a patient from determir to degludec. The confirmed hypoglycemia rate also, when compared within degludec and determir, are not different. However, they are different when you compare degludec to glargine. But overall, the incidence of hyperglycemia with ketosis is significantly less with the second generation basal as compared to the first generation determir. So degludec achieved equivalent long-term glycemic control with similar rates of hypoglycemia. However, hyperglycemia with ketosis was significantly reduced in those treated with degludec. Now you would ask then why somebody should not shift to determir, and why should they from glargine, but why should they shift to degludec? Now we've all seen in practical experience from the last few years that when we were using determir, many times we had to give it twice a day. And even the package insert says that for an ideal result in many children, it has to be used twice a day. So here, if you do a head-to-head comparison between once a day basals, generation 1, generation 2, glargine and degludec fares better in hypoglycemia. But if you do it and if you exclude the once a day thing, then the hypoglycemia rates are not very different. Now, how does a long half-life translate into a practical benefit? Now, this is a basal insulin analog with a half-life of 12.5 hours. And this is a newer basal insulin analog with a half-life of 25 hours. So the peaks and the trough are not very pronounced. And so it leads to a flatter action profile. And with a flatter action profile, obviously, logically, you would expect a lower glycemic variability. What happens when you miss a dose? If the profile is flatter, missing a dose would not have that pronounced effect as compared to missing a dose on a profile which has a very steep peak and trough action. And even if you change the time of the dose to different times of the day, if the gap is more than 8 hours, and you would still expect that the flat profile that the basal insulin has created over the days would still hold when as compared to some insulin which has a lower half-life. Although the difference, I would like to make a point here that the difference in these flat action profiles between both the second generation basals that are different. Your degludec would reach a better steady state in 3 to 4 days, whereas glargine 300, by virtue of the way it has been packaged, would take 5 to 6 days to reach the same steady state. Now let's compare the other Glargine 300 versus Glargine 100. Now this was the Edition Junior study where children and youth with type 1 diabetes were included. The conclusion very quickly was that Glargine 300 provided similar glycemic control to Glargine 100. Both insulins had similar safety profiles, and there was a trend towards a lower risk of severe hypoglycemia and hyperglycemia with ketosis, same with the newer generation Glargine. The addition 1 plus 2 plus 3 type 2 this was addition 1, 2 and type 3, type 2 in type 2 diabetes. Overall, there was less weight gain with Glargine 300 versus Glargine 100 when you compare, and A1C reduction was almost similar in both arms. So newer basal insulins head to head. Now, how do they fare against each other? Now, overall, the HbA1c reduction is pretty similar when comparing Glargine 300, Glargine 3 and Degludec. The time in range is also comparable. Here you see, although when you see the lower two columns in the table, the time above range being a little more with Glargine, time below range being a little more than Degludec, it is not statistically significant. Overall, there is comparable time within range. We have been listening to a lot of propaganda about hypoglycemia, how Glargine 300 fares better than Degludec. But if you see carefully the data, although the confirmed hypoglycemia less than 70 milligrams per deciliter is lesser with Glargine 300, and that is what has been told to us over and over again. When you see confirmed and significant severe hypoglycemia, there is no difference between Glargine 300 and Glargine 100. No one insulin scores over the other. Now, real world evidence, when adults with type 1 diabetes were switched from first generation basal to either Glargine 300 or Degludec 100, and time in range profiles were analyzed. The time in range is similar, time above range, time below range profiles overall are very similar. If you try to dissect it for one period of time and you bring it forward that the differences favor one insulin, it is overall, when you see, there is no difference whether you see symptomatic hypoglycemia or severe hypoglycemia. So in real world settings, but this has been done in adults, the effectiveness and safety is very similar in both insulins. So very recently, published in Diabetes Care, it's a head-to-head comparison of clinically equivalent doses in the real world in type 1 diabetes. Now, after 3 months of treatment, the HbA1c reduction is very similar. Although there is greater suppression of endogenous glucose production, free fatty acids, glycerols, and beta hydroxybutyrate with Glargine 300, this is limited to only during the first 12 hours. Pharmacodynamic variability, yes, there is a 23% lower variability with Glargine 300 versus Degludec 100, but overall, the glycemic control is very similar and pharmacodynamic equivalence is there with clinically titrated doses of Glargine 300 and 100. So obviously, this means that you have a patient, you titrate it the way you would titrate insulin in that patient, and if you achieve a acceptable state with the glycemic values, the insulins are pretty much the same. Then the ultra rapid Lispro, which has been FDA approved. Now, what is the difference? We all know that ultra rapid aspart was approved a few years back. Now, this is also an added excipient to the existing Lispro, which comes by the name of Humalog that you all know, in order to speed up the absorption. So it is a treprostinil compound, which is a prostacyclin analog, and it enhances the absorption of Lispro via local vasodilation. It doesn't have any systemic side effects. But please remember, this is not the pegylated Lispro that was discussed a few years back. Pegylated Lispro is now no longer a molecule in contention because of the very significant transaminitis that it used to cause. So we are not, this is not PEG Lispro, this is the URLI, the ultra rapid Lispro. The trial results of ultra rapid Lispro, which have led the FDA to approve it, are the Pronto type 1 diabetes study, which showed its good glycemic control, non-inferiority to Lispro, and it was a superior postprandial control. Within the pump also, it has a safety profile similar to Lispro. We still do not have any experience using it in our country. It will be very interesting to use it and see how well it really fares. But Technosphere insulin, the inhaled insulin that was very much in the news a few years back, seems to be making a comeback. We are not sure yet. So this was a randomized trial which happened in Australia. And the HbA1c values were similar at the start of therapy as well as at the end of the trials, at the start of the trial as well as the end of the trial, the glucose values after a standard meal were significantly lower with inhaled insulin in the first 90 minutes post-meal compared to the standard analog insulins. And hypoglycemia, interestingly, was also significantly lower with inhaled insulin compared with the other insulin. In fact, the reason why it was really withdrawn 4 or 5 years back with a lot of incidence of cough in the recipients, there was no increased incidence of cough. Pulmonary function was not affected on or off the drugs, but has to be taken. But the trial was very small, only 130 participants. Also, it intended to take 250, but maybe the criteria were so loose that they achieved the endpoints very early. Also, it was a pharma-funded study, so we really need to look at this space as to how this space unfolds in future. Is it a time to write the obituary to Glargine? Not necessarily. There was a very interesting trial where they use a needle-free injection of Glargine versus same injectable Glargine, although in type 2 diabetes, and they saw the results on the flash glucose monitoring. And the patients were on significant dose, 12 to 18 units per day, and they were randomized, jet, injection, jet. And interestingly, those who received the same Glargine with the jet injector had a significantly lower mean glucose, lower maximum glucose, lower time above range. In fact, almost all the parameters were better. And there was no difference in glycemic variability between the two groups. Still remains to be seen why this happened. And maybe we are looking at another avatar of the same first generation basal. So in conclusion, insulins are progressively improving. Newer basal insulins provide an edge over generation 1 basals, but the role of generation 1 basal is still very relevant. The message from this discussion should not be that Glargine 100 is going to be obsolete. Not at all. Glargine, the difference between generation 0 and generation basal insulins is huge. The difference between generation 1 basal and generation 2 basal is not that big. So it does not mean that all patients who come to you have to go on a generation 2 basal. Glargine 100 is still a great molecule, still achieves our glycemic targets, still achieves a very somber, very acceptable hypoglycemia profile. So it is still very, very relevant, although it is always better, it is always interesting to look at the improvement in molecules. There is limited evidence as of now to choose between newer basal insulins. From the parameters analyzed, they fare very well head-to-head, and faster Lispro is not FDA approved, and the search for an inhaled insulin may be in for a revival in the time to come. Thank you very much, and I would be very happy to take any questions.
Thanks a lot, Saurabh, for a wonderful talk. It was a very good illustration with regards to the newer insulins which are coming up. And I think you rightly pointed out that when we talk about a 0 to 1 change, it really came up when we used to have NPH, and then suddenly we had Glargine and Detimir which came up, which really changed the overall picture. From there, it was like 0 to 1 change. From there, it is an incremental change which is happening in terms of U300, which has done changes, and Degludec, which has come changes. But if you are using a good long-acting insulin and cost is an issue, I think Glargine at the moment 100 will be very good from that perspective. Of course, if you are looking at subtle changes, U300, Degludec, they are pretty much at the moment, there's nothing much to say, differentiate them. Both of them are very good in terms of that. But then the cost factors also we have to decide and discern on that perspective. Do you see any future of very, very long-acting insulins? Like you can, many people talk about basal insulins which do not require a daily injections, maybe a more weekly and those sort of things. Do you realistically see a chance of that?
When it comes to our population, I am very skeptical because one wrong injection will make the family run around for 1 week, and that is a little too much to ask. Obviously, in type 2 diabetes, there are molecules which are once a week, and there may be a role for a basal insulin in that patient population. But I'm a little skeptical for the population that we serve.
Exactly. And rapid acting, I don't think, do you think much changes will happen in rapid acting? It's pretty much at the peak. Probably at the moment, there's not much desirable. The only thing would be the basal also. Now I think we are near perfection. But if somebody says this is perfection, 10 years later, you will see something entirely new and this will change the way it is. So I think it was a really wonderful talk. We'll see if there are any questions there. Are your patients on functional insulin therapy? Do you use Glargine or NPH? So it's not very clear. So I think probably they're trying to ask about in basal bolus, can you use NPH as well if the affordability is not is the issue? So I think, yeah, Saurabh, I will let you answer that.
Should I take it, sir?
Yeah, please. Yeah.
Yeah. So NPH is still an option if the affordability issues are there. So the way we use it is we mix it with regular insulin and then make it 1 injection in place of 2 in the morning. Although it is a challenge, it is a two-way challenge. One side, you are reserving this insulin for somebody who cannot afford it. But the kind of intelligence that you need to mix a regular and an NPH insulin day in, day out may be absent because of the circumstances around the same patient. Although there is another indication where we use NPH, sometimes in some children, we mix it with regular insulin for those kids who have a long time in school. So we need a longer coverage for them. So NPH is still not out of vogue. Very small children, sometimes infants, sometimes toddlers, they sometimes do well on twice a day NPH. So there are still places where we use NPH, although the ambit has become very, very limited, especially with the approval of Degludec in children more than 1 year. So the ambit of NPH insulin has become very limited.
So I think that was a wonderful discussion. So probably what we're looking at is in the near future, we will be going more towards the second generation insulins, especially with regards to the basal insulins. And maybe next time we talk, we'll have much more evidence on the third generation might have come by that time, because when you have two competitors going on, there'll always be something new which is going to come up.